Dear colleagues, welcome to the first EACTA webinar entitled Routine Cerebrospinal Fluid Drainage for TEVAR. Let me introduce myself. I am Purificación Matute from Barcelona, Spain, and I am the present chair of EACTA Vascular Subcom. It's a great honor for me to chair this first webinar. Firstly, I would like to thank Dr. Mohamed El-Tahan for organizing and coordinating this presentation. And also, I would like to thank the moderators and speakers for their collaborations to talk about this interesting and exciting topic. All speakers are experts in this subject. Now, I would like to introduce Dr. Dragana Unik Stojanovic from Belgrade and Dr. Simon Howell from Leeds. Both are delegates for Vascular Subcom, who will introduce the rest of the speakers and moderate this panel. I hope you enjoy and clarify everything about this topic. Thank you very much for your attendance, and please, Simon and Dragana, present and introduce the next speakers. Thank you very much.
Fucci, thank you very much indeed for that. It's my pleasure to be one of the joint moderators for this first EACTA webinar. The objectives of this webinar are to update you, the audience, about the current evidence and best practice for routine CSF drainage, and to promote and rehearse the practical skills required for CSF drainage and appropriate decision making around that procedure. The webinar consists of 4 talks from 4 experts, as you have heard. You will first hear from Dr. Kavita Khemlani about the background and evidence for cerebral spinal fluid drainage. We have talks on the pros and cons of routine CSF drainage for TEVAR from Dr. Daniel Bolliger and Professor Balthazar Burley. And finally, Professor Jan Schreiber will talk through the practical aspects of CSF drainage. The talks will last approximately 25 minutes each. This is very much an interactive webinar, and I would encourage you to type questions into your web browser, which will come through to myself, and I will feed them through to myself and Dragana will feed them through to the speakers at the end of the session. The aim is approximately 25 minutes for the talks, and then 5 minutes of questions. Could I please encourage you all to complete the post-feedback survey at the end of the webinar, which will then allow us to issue certificates of attendance. And then, without further ado, it is my pleasure to introduce your first speaker, Dr. Kavita Khemlani, who is going to rehearse the evidence and speak to us on contemporary cerebral spinal fluid protection in thoracic and thoracoabdominal aortic surgery. Kavita, thank you very much indeed.
Thank you, Simon, for your kind introduction, and welcome to our first EACTA webinar. My name is Kavita, as Dr. Simon Howell said, and I will be giving you a short overview of different spinal cord protection methods during open and endovascular approaches. First of all, I have to state I have no actual or potential conflicts of interest in relationship to this presentation. So why is protecting the spinal cord so important? It's important because aortic disease is a very important disease nowadays. It has a major impact on the mortality rates around the world. And in the US alone, it is the 12th leading cause of death, leading up to about 45,000 deaths per year. And in Europe, that's an estimated 110,000 deaths per year. There's a survival range of 5 years of between 13 and 50%. And it's a disease that affects more men than women. And the pathology that carries the highest rate of morbidity and mortality is the thoracoabdominal aortic aneurysms. So the mortality and morbidity of aortic repair has improved since the implementation of endovascular modalities. However, it is still the most devastating complication of both approaches still remains spinal cord injury, which I will be naming SCI for the sake of this talk. SCI leads to neurological deficits ranging from complete flaccid paraplegia to several gradations of temporary or permanent paraparesis. And this also includes fecal and urinary incontinence, which are not only a health issue, but also a psychological and social issue as well. Patients have a very hard time accepting and managing this problem, and the the emotional component is tragic. They also have to deal with the loss of disturbed or loss or disturbed sensation, which can lead to bed sores, which also leads to infections, and it's also a huge health cost. Furthermore, the SCI does not only reduce quality of life, but it also carries an increased 30-day mortality. Also, the 5-year survival of the group that has SCI is lower than the group that does not have it. And as I have mentioned before, it is an increased cost of health care. So what are we talking about? What are the incidences of SCI during open surgery? Well, it depends. There's a range of, it ranges between as low as 3% to as high as 8%. And it depends on whether you look at the TAAs alone or you take the whole group of TAAs and the thoracoabdominal aneurysms, or whether you look at paraparesis alone or paraplegia alone. Moulakakis and his colleagues had a review in 2018, and they had a pooled incidence of SCI of 8.2%, and when they looked at paraparesis alone, it was 3.6%, and for paraplegia, it was 5%. Is it the same thing for the endovascular approach? Well, what is noteworthy is that the endovascular approach, the SCI range is very wide. It ranges from 1 to 16%. And the Eurostar registry gives us an incidence as low as 2.5%. But an article by Bistas in 2015 gives us a rate as high as 16%. Our colleagues in the Netherlands, Dijkstra and all, they also had a review, and they look at also at the transient incidences, which comes up to 5.7%, and for the permanent, it was 2.2%. So, what is the etiology behind this spinal cord ischemia? We all know that it is multifactorial. And I think it is important to say something about the timing, because it can present immediately after the repair or even several hours to several days after. According to an article by Dessart, most of the patients, which is like 70%, present with delayed spinal cord ischemia. There's two types of the etiology. With the immediate type, you have a reduction of spinal cord blood supply leading to irreversible ischemic insult. And in the delayed one, you have ischemia and reperfusion injury, which leads to edema and a relative increase in spinal cord cerebral fluid pressure. So just briefly, I want to mention the two paradigms concerning spinal cord circulation. Two models. The first one is based on the anatomy, and it proposes that the most important input for the ASA, so the anterior spinal artery, arises from the artery of Adamkiewicz, arising from segmental arteries in the lower thoracic or upper lumbar region. And this difference this is different for in difference in population. The other paradigm is the collateral network, which relies more on a dynamic demand-depending supply. So what are the risk factors for spinal cord ischemia? Multiple studies, they mention risk factors that can be applied to both open and endovascular approach. And some of the risk factors that can be applied to both approaches include, but they are not limited to, the extent of aortic coverage with a cutoff of around 20 centimeters, so the length of coverage. Also perioperative hypotension or prior aortic surgery. And then the most important one would be the abdominal aortic surgery. And subclavian artery coverage, and female gender. So how can you prevent spinal cord ischemia during open repair? Current literature offers multiple strategies for spinal cord prevention. You can minimize ischemia time. You can preserve spinal cord blood supply. This can be achieved by selective revascularization of the critical intercostal arteries, and also by preserving the subclavian and hypogastric arteries. Also avoiding simultaneous repair of the thoracic and abdominal aneurysm. Sorry. Hypothermia is another method to increase the tolerance of spinal cord to ischemia. You can do the hypothermia systemically or regional by epidural cooling. You can use both, or pharmacologic neuroprotection. And the pharmacologic neuroprotection, I want to name some agents like the thiopental, the steroids, which reduce inflammation, thereby reducing spinal cord injury, and naloxone. And I want to tell you a little bit more about the naloxone because it has been known for some time now. Acher and al. In 1994, they had a retrospective analysis of about 110 patients, and they looked at patients who received either a combination of cerebral.
This meant a lot of work for the speakers. So on behalf of the board, I would like to say that we are really indebted to them because they were really very brilliant and so committed to this webinar. It is my pleasure also to thank the EACTA Vascular Scientific Subcommittee, and in particular I would like to thank Dr. Purificación Matute, who was the chair of this webinar, and Simon Howell and Dragana Junic, who were the excellent moderators of this webinar. Also, I think that a special thank has to go to the Social Networking Task Force and to MCI for advertising the webinar. And last but not least, a special thank to the committee of EACTA, and in particular to the chair, Professor Mohammed Al-Tahan, whose effort made this webinar possible. So really, thank to all these EACTA people who worked very hard on this project. And a very, very special thank goes to all our friends and colleagues connected from all over the world for attending the webinar and making this webinar possible. We could have excellent speakers, but with no audience, the webinar would not be a success. And then I take the occasion to announce the next EACTA webinar from the Thoracic Scientific Subcommittee, which will be held on March 25. So please mark your calendar on March 20. We'll have a very interesting webinar held by the Thoracic Scientific Subcommittee. So thanks everybody for joining and participating, and